Okay. So I'll first of all I will introduce myself for the patient. I will ask her about her age, name, occupation, identify her ethnicity. I will ask her about her last menstrual period and if this pregnancy dated by early ultrasound uh, or uh, uh, or by LMB. I will ask her if her cycle was regular or not. I will ask her about maternal screening tests she did any and serology tests about her vaccination history and if she has nausea, vomiting, any vaginal discharge or vaginal spotting or bleeding, any any antenatal admission before, and I will ask her if she did ultrasound before or not, and if they detected any anomalies or not. I will ask her about her past obstetric history, about her parity, mode of deliveries, birth weights for the previous babies, and if there's any congenital or chromosomal abnormalities, about her menarche, last menstrual period, the regularity of the cycle, intramenstrual bleeding, history of contraception, BID, sexually transmitted infection, history of dysmenorrhea, dyspareunia. I will ask her about her medication. She is on any medication, antihypertensive, insulin, analgesics, folic acid, multivitamins. I will ask her about if she is a smoker or not on any recreational drug, and family history of chromosomal congenital anomalies, mental retardation, consanguinities. Then I will do like general examination for her. I will check generally. I will check if there is any signs of anemia, and if there is thyroid enlargement. I'll just check cardiac, S1, S2, any murmurs, respiratory. If there's any and abdomen, I'll check fundal height, fetal lie, position, presentation, laxity, any scars, any peritoneal signs. Then I will do an inspection on the pelvis, and I will do ultrasound before that to check fetal presentation, placenta localization, amniotic fluid, and estimated fetal weight. Then I will do by inspection pelvis if there is any abnormalities. Then I will do like by speculum to check the cervix, and I will do like bimanual examination, cervical, os closed or dilated, and lower limb if there is any edema. Then I will ask question. You will ask her to diagnose her condition. I will do investigations for her, CBC, coagulation profile, liver function, renal function, urine culture, urine analysis, and actually my differential diagnosis right now is either oligohydramnios or fetal growth restriction or or wrong dates, or constitutional, small for gestational age. Hello? Okay, so she's sure about her date and she had history of abortion. 13 and 14 weeks. Uh-huh. So this might be like fetal growth restriction. Okay, and how I will arrange, I will check umbilical artery Doppler, and I will do uh, cerebral artery Doppler also to exclude anemia, and I will counsel maternal fetal medicine to follow her up, and I will do those investigation. I will do torch. I will do RH. I will check her blood group RH, and I will ask her about her husband blood group also. Exclude. Mm, yes. Mm-hmm. Okay. And I will do those routine investigation, and I will follow her up um, after I check umbilical artery Doppler. I will follow her up like every 3 weeks for a growth scan, 3 to 4 weeks for a growth scan, and every week for umbilical artery Doppler, and I will give her corticosteroid at like I could give her now corticosteroid actually. I can give her dexamethasone, either dexamethasone or betamethasone 12, betamethasone 12 for 2 doses, and dexamethasone 6 for 4 doses. And according to the course of follow up, if the baby is good, umbilical artery Doppler is good, growth is good, I might deliver her at like 38 weeks, from 37 to 38 weeks. Every week Doppler, I will Doppler every week, and non-stress test as non-stress test, and the growth scan every 3 to 4 weeks. Sorry, Doctora, give me the question again. First of all, I will do a non-stress test for her and biophysical profile, and I will check umbilical artery Doppler as well. And according to the grade of biophysical profile, I will, and according to the results of umbilical artery Doppler, I will deal with her situation. Mm. Like her is 6 and the lower range, yes. So, in this case, if it is reduced, it is like she might be in the lower side, and it might be illegal also. So it is like I can give her like 6 out of 8 by physical profile. So in this case, I will repeat by physical profile and I will repeat my physical profile in the after 24 hours, and if it's still the same, I will go to deliver her. Okay. At the time of delivery, okay, he might have fetal distress. Um, uh, Also, he might have hypoxic ischemic encephalopathy, intraventricular hemorrhage, hyperbilirubinemia, hypoglycemia, hypocalcemia. Um, huh? I will counsel her regarding she has to like have like preconception and folic acid multivitamins and early follow up to reduce the maternal complication and the fetal consequences that could happen. And we can go for antiphospholipid testing also before conception. We can order for her anticardiolipin, anti-beta-2-glycoprotein, lupus anticoagulant to check if this was because of antiphospholipid syndrome. And yes, close monitoring for. Mm, 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 mm. Okay. The patient you are about to see has been referred to gynae outpatient clinic by her. The referral is given below. Read the letter and obtain relevant history from the patient. You should discuss your initial impressions, her problems with the patient, and provide a review of the This had lived surgery 4 times in the last 6 months, claiming of weak pelvic pain and offensive vaginal discharge. Various result has all been negative. I should be grateful for your advice. Okay. So I'll introduce myself for the patient, ask her about her age, name, ethnicity, occupation. I will ask her about the onset um, of this discharge, and first of all, I will ask her about the pelvic pain, the onset and the duration, characteristic of pain, if it's like continuously, intermittently, aggravated at night or in the day, specific hours during the day she has this pain, aggravating factors, alleviating factors, if there was any medication she used to relieve her pain, and did she do any radiological imaging to diagnose what is this pelvic pain came from, and and I will ask her about the investigations she did, and if there is any reports she has with her now regarding that. I will ask her also about the offensive vaginal discharge, the onset, the duration, and characteristic, and she had if it's like constantly, continuously, or intermittent, and if she had any medication for that, relieved or not, aggravated or what, and if she had any cultures for that, the investigations she did, the medication she tried, and what kind of surgeries she had also. As in the report, there is 4 times surgery, what kind of surgery she did, the site of surgeries, and mm, laparotomy for what she did. Laparotomy for what? Okay. I will ask her if she has any chronic medical illness. She has epilepsy, diabetes, hypertension, thyroid problems, if she had sexual harassment, sexual abuse, she exposed to domestic violence. Uh, yeah, okay. Then I will tell her that um, uh, feel free to talk, because as a domestic violence is spreading, from every 7 women, one woman of them is exposing to domestic violence. Just feel free to talk if you have like harassment at home, violence at home. I will assure you that everything gonna be between us, gonna be highly confidential. Nobody will know about it. And I will ask her if she feels, I will, I will ask her if she feels safe to go home, and also if she has like, if she is really exposed to domestic violence, she did like plan to escape from home. Also, I will ask her about mm, I will ask. Mm, okay, so in that case, I will tell the patient, first of all, as you have يعني, don't worry, whatever happened here is going to be between me and you. And I will ask her if she wants to tell anybody, as there is, as we have social workers here could help you regarding this issue, and there is like Women Protection Association also. We can inform them to help you if you want me to help you in this way. Or if you have like escape plan, your keys, your clothes, you put them in a bag, and you put it in your neighbor or in your friend house. And if you are like financially stable to support yourself or not, um, and regarding your children, I will not promise you that it's going to be between me and you, because I will inform the Child Protection Association, because this is not accepted. And also regarding offensive vaginal discharge, I have to make like a swab, vaginal culture, to check what kind of organism, and to give you a proper treatment for that. Have all been negative. I should be great. So offensive vaginal discharge. She might have sexual harassment also. She has injury. So I'll do physical examination to be sure about that. So I will her vulva, if there's any bruising, any hematomas, any injuries, any wound. I will do speculum to check if there is injuries, laceration, tears, and I will provide her a proper treatment, and I will give her information leaflets about domestic violence, how to protect yourself, and how to provide protection for your children. And for sure, I will inform about this children abuse for Children Protection Association. But for her, it is up to her if she wants to escalate it about herself. But children, no, we will escalate it. Yeah, I will document her words also. So if any times anything happened, this gonna protect her and protect me as well. Yeah. Mm. Mm. Come to delivery room immediately. So to borrow number because undiagnosed which presentation happening in which are asked to discuss with the how you will proceed and will then be asked a number of questions. So, okay, first of all, I will go immediately to the patient. I'll introduce myself. I will be sure I'll ask her about her name, and I will be sure about her MRN number. Then I will check with the midwife what is the issue, what is the problem. She said undiagnosed breech presentation. I will ask the patient, is it imminent? Is this scenario imminent, like she is fully dilated and I have to deliver her right now? Hi, Doctora. Is the delivery imminent, like she is fully dilated right now? Uh, okay. So mm, I will ask her if she was following up before, and if she was following up, where is if she has the report of her following up to check the fetus the baby weight, and if she has, like, I will ask her if she is DM, if she is DM, hypertensive, and any medication, and to exclude like macrosomia. Then I would go to, يعني as it is 7 p.m. I would go immediately to deliver her يعني. So okay, I will deliver her. I will deliver her. I will let the breech come to the umbilicus. Then I will do like assisted breech delivery. Then يعني I will deliver her the anterior arm first, then the posterior arm. Yeah. يعني I don't know if this question wants me to do like the steps for breech delivery. I will inform my senior immediately that I have a breech presentation. This patient is not following up. Can see him dilated. I will ask him to come, and we will check like fetal weights if we can, and if it's suitable for breech delivery, we will. I will call anesthesia. I will call pedia. I will try to deliver her also vaginally if everything is suitable, like the weight is good, suitable for delivery. I will prepare Piper forceps in case of anything happened. Also, I'll tell the nurse to prepare it, and I will go to deliver her breech. يعني. So, what are your questions right now, Doctora? She can have. She can have like third, fourth degree perineal tears, cervical tears. She could have trianatomy, PPH. She could have like failed breech, and she could lose her baby. She could have CS. DVT, PE, yes. Yes, those are the complications that she might have. He can have like intraventricular hemorrhage, brachial plexus injury, an ICU admission, CP, low pH, low Apgar score, hyperbilirubinemia, hypothermia, hypocalcemia. Mm, mm, okay. Let me remember this. Okay. To deliver the legs, the lower limbs, I will go for Pinard maneuver, and after I do Pinard maneuver, I will let breech deliver spontaneously. Then I will assist the breech. First of all, I will deliver the anterior arm. Then I will rotate the baby to deliver the posterior arm. Then I will do Morris Smith maneuver to deliver and flex the head to deliver it. And I will put like 2 fingers, the index and thumb behind the neck, and I will deliver the baby in flexed position. Mhm. Yes, I will give her osteotomy. I will actively manage the third stage of labor. I will give her I will assess the tears, and I will give her immediately oxytocin, try and massage, and I will check the bleeding. If it's controlled, I will go and manage the tears. I will suture them immediately. And if it's still bleeding, I will go for like misoprostol, hemapat, ergometrine, according to the position, according to the situation. Mm. Immediately, I will handle it to the pediatrician, and the pediatrician gonna control all the issue. Yeah, I will after delivery. Yes, I will document whatever happened, and I will document the way of delivery. If there's any difficulties, if it's spontaneous or not, the Apgar score, the cord pH, and the time of the BD handled the baby, and I will. Mm, 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 mhm, 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 mhm. She is known to have a twin following IVF treatment. Ultrasound shows the first twin is breech. But we will tell her about this finding, justify subsequent investigation, and evaluate the factors that will influence the decision and timing of the delivery. Okay. What you will tell her about this finding? Okay, first of all, I will just introduce myself for the patient, ask her about age, name, ethnicity, occupation, gravity, parity, and her last menstrual period, and if this pregnancy was spontaneous or by IVF, pregnancy following IVF. Okay, and what time of IVF, and I will ask her if they are what kind of twin she has, monochorionic diamniotic. Okay, and I will tell her about maternal serum screening. No, she cannot do maternal serum screening. I will about her serologies, vaccination history, and if she had any event during this pregnancy, antenatal admissions. She has she broke her amniotic fluid. If there is bleeding, if there is abdominal pain right now, then I will ask her about her past medical history, if she's DM, hypertensive, thyroid, autoimmune, gynae history, her menarche, LMB, regulative cycle, history of infertility, contraception, PID, and past obstetric history, her parity, mode of deliveries, birth weights, healthy babies or not, about smoke, if she's a smoker, and recreational drugs, family history, if there is chromosomal congenital abnormalities, mental retardation, consanguinity, infertility, thus. Okay. I will do I will do first now like pelvic examination. I will check the fundal height. Okay, and I will do ultrasound to check the amniotic fluid, the growth discrepancy between both babies, as they are more liable for 2020 transfusion syndrome, as they are monochorionic diamniotic. I will check all those parameters, Doppler, I'll check the bladder of both fetus, amniotic fluid index, growth discrepancy, and I will do for her CBC coagulation profile, and urine culture, urine analysis, and vitals, and I will check her BMI. Okay, evaluate the factors that will influence the decision on timing of delivery. There are multiple factors that, first of all, this patient I will order for her non-stress test as well, as she has reduced fetal movement. I will ask her if this movement, just now she felt the onset of reduced fetal movement just now, or it was repeating event, and how does she count the movement, if she properly count the movement or not. And I will tell her how to count the movement, like you have to be in a recumbent position at night, a quiet place for like 1 hour, just count them, 1 to 2 hours, count them. It should be 10 movements to have a proper movements. And if it's really reduced fetal movement, I will go for Doppler. Okay. And biophysical profile. And I will exclude that she has a twin-to-twin transfusion syndrome. And as she is monochronic, diaminated, reduced fetal movement, if biophysical profile and Doppler is good, I will admit her for observation and kick count. And if still there is reduced fetal movement, I will go to deliver her. I will give her a steroid in this period, and tocolytics until she gets steroid. Then I will go to deliver her either by induction. No, I will go to deliver her by CS, as the first baby is breech. So I will deliver her by CS. First of all, I will inform pedia, maternal fetal medicine, and anesthesia, cross match 2 units of blood, 2 to 4 units of blood, um, uh, like um, um, mm, yeah, mm, mm, yeah. Mm, mm, yes. Mhm. Okay. Schedule labor for post-term dates. Treatments was administered to induce labor. And the 15 month patient several hours later. Artificial recommends recommended slightly. Patient tried to eliminate that culture done from vaginal endometrium over 56 weeks was negative for group streptococcus bacteria that sometimes can the team happened to review the facts record and noted the positive urine culture. She immediately ordered antibiotic and delayed ARR visit to allow time for advantages. Who will you inform the patient about it and what will be your subsequent action? Okay, this is near miss. Okay, yes, near miss. So, shall I inform this patient about it? Wallahi, I don't think so. Near. Okay. I will not tell because the patient already took antibiotic at the proper time and we prevent the infection to happen to her. So why I would tell her something didn't harm her? We didn't harm her. She took the proper antibiotic even if there was delay. She had it, and the baby do not have like any infection. So I wouldn't tell her, but but um, but I would do like an incident report about whatever happened from this junior resident to improve the quality of the management next time. I would like raise risk management analysis team, and I will be sure that this we will analyze what happened and we will do like meeting and we will do report and we're gonna like make an audit to improve whatever happened, and we're gonna talk with the junior also. Yes, like this. What do you think? Mm. Yeah. Mm. دكتورة, what is analysis fish? Fish, it is abbreviation for what? Mm, 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 mm. Yeah. Okay. Mm-hmm. Mm-hmm.